And to note that in the last two talks last weekend, we talked a lot about Jewish decision-making in a sort of general sense. So we thought in the first talk about how to engage Talmudic sources as a discussion partner around ethical questions. And then in the second talk, we looked at different rabbinic models of decision-making. And I'm going to refer back to some of the ideas from those talks towards the end of my lecture today. But what I want to do together today is think about Jewish decision-making in a much more specific or concrete sense. How can we draw on Jewish tradition to address specific questions that arise in our lives? What should we do if there's no clear precedent or guidance that corresponds to our situation? And I want to think about those questions by looking at two different types of issues that have arisen as the result of the COVID-19 pandemic, because this is in many ways an unprecedented situation. So it's exactly the kind of situation where you might say, we don't have established guidance, what should we do? And the questions that I want us to think about together participate in what we might call triage ethics. Triage ethics addresses the questions that arise when there's not enough of a resource for everyone who needs it. So the first sort of set of questions we'll look at is one that most of us are unlikely to have to answer personally in our lives unless you're in the medical profession. And this is questions about what should doctors do, how should they decide which patients should be treated first or which patients should be treated at all if there is not enough of a medical resource available for everyone who needs it. And we'll look at two cases in particular: access to an ICU bed and in the intensive care unit, and also access to a ventilator. And we'll look at what two different rabbis have said about those situations. And then the second question I want us to think about together is one that many of us are likely to encounter, which has to do with access to the vaccine. So if we're able to access the COVID vaccine, and some of you may already have gotten it, some of you may not have, but if we think we're comparatively low risk for serious complications from COVID, is it ethical for us to get the vaccine while doses are still in short supply? So two very different types of questions, but both of which have to do with limited resources, not enough for everyone who needs them. And I'm going to go ahead and share my screen and just share some slides so that we can look at some sources together. These are going to be a somewhat different type of sources than last time because I'm going to look at some more contemporary thinkers. But I want to start off our conversation first by just thinking a little bit more about what triage ethics is and how it works. So specifically in a medical context. So triage comes into play when doctors need to assign degrees of urgency to different patients so that they know what order to treat them in. And it only becomes necessary in cases of limited resources. So this could be there's a limited number of doctors available and more patients that need to be seen than there are doctors. It could be there's a limited amount of a medicine or another medical technology. And many of us have probably experienced this. If you've ever been to the emergency room, you've likely gone through a triage process. So if you came into the ER with a broken arm, you may have found yourself waiting for hours while the doctors treated other patients who came in with a heart attack or a stroke or a seizure. Those patients whose survival depended upon receiving immediate care were granted priority over you, since while you may have been in a lot of pain, people do not usually die from a broken arm. So that may have been the case if you came in at a busy time, but if you came into the ER at a relatively quiet time with your broken arm, you might have been seen right away. This triage process only comes into play when there's not enough resources to go around. In that scenario, it's often not enough doctors to see all the patients, but it could also be other types of resources like the x-ray machine. There's only one x-ray machine and lots of people need to use it, so you have to wait for a while. Or ventilators, medicines, operating rooms, all of those different kinds of resources can be in short supply. And typically, patients will be treated or prioritized based on their prognosis and how much their survival or recovery is dependent on immediate treatment. Usually, triage will prioritize those who are the most seriously ill or injured. So broken arm, you're going to wait for a while. Middle of a heart attack, you're going to be treated right away. But sometimes in cases of truly limited resources, patients who are extremely ill and or unlikely to recover from severe wounds may be passed over so that those resources can be focused on those with a better chance of recovery. So if the doctor makes the assessment, this person is not going to survive no matter what we do, any treatment that we offer might prolong their life by a few hours, but we're not going to be able to save them, they might, in extreme circumstances, not treat that patient in order to treat someone who has a better chance of recovery. And a classic example of this actually comes up if you think of like an army field hospital in the middle of a war, and lots of people are suffering from gunshot wounds and explosions and things like that. Some people may be so severely wounded that they just cannot be saved. And if there were no other patients around, the doctors would try to save them anyway. But if there are other people who need medical care, they might not treat that patient in order to prioritize those who can be saved. So this idea of triage is very common to secular hospitals, but they also impact ideas about priority of care in halakha as well. And before we turn to the contemporary cases, I want to just share with you two classical sources, two Talmudic sources that are often invoked in the context of thinking about triage. And both of these sources raise the question of whether it is ever okay to save your life at the expense of another person. So the first source, from Sanhedrin 74a, introduces ideas that I would bet are familiar to many of you, even if you've never read this passage in full inside in this Talmudic context. The source explains why it is not permissible to kill somebody else to save your own life. And many of you may have heard this idea that in Judaism, there are three things you can do almost anything to save a life, but there are three things you cannot do. You cannot commit murder, you cannot commit certain acts of sexual immorality like incest, and you cannot commit idolatry. So this is one of the sources that talk about why you can't commit murder. So let's read it together. From where do we derive regarding a murderer himself that one must allow oneself to be killed rather than commit murder? Okay, so how do we know that you can't kill somebody else to save yourself? Answer, it is based on logical reasoning. And part of what the Gemara is saying here is there's not a verse in the Torah that says this, but we can infer it through logic. And they give an example. A certain person came before Rabbah and said to him, the Lord of my place said to me, go and kill so-and-so, and if you do not, I will kill you. Rabbah said to him, it is preferable that he should kill you and you should not kill. Who is to say that your blood is redder? In other words, that your life is worth more. Perhaps that man's blood is redder. So here, the Gemara is talking about a specific context where you sort of imagine one person has a gun to your head and says, if you don't shoot that guy, I'm going to shoot you. And they say, you can't kill the other person to save yourself because you can't know all life is of inherent value. And even if our lives as individuals are more precious to us than anybody else's, we're attached to our own lives, we can't actually know that we are more valuable than somebody else. Every person has inherent value that cannot be sort of weighed next to somebody else. So you can't say this person is of greater use to society than that person will prioritize their life. You can't say, I love this person more than that person, I'll prioritize their life. All life is of inherent value, and we can't know whose life is worth more, whose blood is redder. Now, the same kinds of questions, can we prioritize ourselves over others, comes up in a very different context in Bava Metzia 62a. And again, this is a relatively well-known passage. You may have heard it before, but it has to do with limited resources more specifically. So more sort of directly now connected to the kinds of cases we'll look at. If two people were walking on a path and there was a jug of water in the possession of one of them, and the situation was such that if both drink from the jug, both will die as there is not enough water. But if only one of them drinks, he will reach a settled area. There is a dispute as to the halakha. So our situation is, imagine these two people were in the desert. There's no other water around, but there's this one jug of water. There's enough water for person A to drink all of the water, make it to a town, get some more water and survive, but person B will die of thirst. There's also enough water for both of them to drink some water and survive for a while longer, maybe a few hours, maybe another day, but they won't survive long enough to reach the settlement and they'll both eventually die of thirst. So we have a halachic dispute. Ben Petora taught, it is preferable that both of them drink and die and let neither one of them see the death of the other. So here, Ben Petora's reasoning seems pretty similar to what we just saw in Sanhedrin. How can you know whose blood is redder? How can we know whose life is worth more? Better that they share the resource, they both live for as long as possible, and then they will both die. This was the accepted opinion until Rabbi Akiva came and taught that the verse states, and your brother shall live with you, indicating that your life takes precedence over the life of the other. So here, Rabbi Akiva is reading this verse, your brother shall live with you, which means you have to be living for your brother to live with you. So you can prioritize your own life. And he here is really saying, we want to try to save at least one life, right? In the first situation, everybody dies. At least in this case, you have the opportunity to save yourself. And we want to maximize the saving of life. So it's acceptable to take the entire resource for yourself. And I think this is important because there's a little bit of a different moral calculus going on in these two sources between actively killing somebody and taking all of a resource so that other people who need that resource to survive don't have access to it. You're contributing, you might say, to their death in some sense, but you're not actively killing them. So the question is a bit different. In Sanhedrin, the question is, one of us has to die. Can I make sure it's you? Can I kill you so that it's not me? In Bava Metzia, the question is it better for both of us to die or for me to save myself knowing that as a result, you will die? So again, in the Sanhedrin context, somebody's going to die, and it's not okay for you to pick which one. But in Bava Metzia, one of us could survive, and it's okay for you to prioritize your survival. Okay, so these two texts hover in the background of Jewish thinking about triage, and there are other sources as well. But they shape the key halachic principles that will guide the rabbis who think about our first set of cases. What to do when there are multiple seriously ill people and there are not enough medical resources to care for all of them. So we'll look at the decisions together of two Orthodox rabbis, Rav Moshe Feinstein and Rav Asher Weiss, who look at two similar cases. The first deals with the shortage of ICU beds, and the second deals with the shortage of ventilators. And both rabbis begin from a shared set of principles, many of which are directly connected to these two sources we just read. So the first principle that they agree upon is that in the case of limited resources, where multiple patients arrive simultaneously at a hospital, treatment should be provided to the person who has the best hope of recovery. So they talk about medical suitability or prognosis as ways of thinking about this. Two people show up at the hospital at the same time. The one who has the best hope of recovery should be given the resources. And I think we can see in this principle an extension of the logic we just saw in Bava Metzia 62a. If we have the opportunity to potentially save life, we should save as many lives as possible. So we're going to prioritize the person who has a chance of surviving. The second principle that they agree upon is that a patient cannot be required to sacrifice him or herself so that another person can receive care. And here I think we also see sort of an extension of the idea in Sanhedrin 74a, that we can't determine that one person's blood is redder than another, one person's life is of more value than another. So we can't say person A needs to forego their right to treatment so that person B can live because person B is more valuable for some reason. Now, I do just want to note there's an important difference in the cases we're looking at than the cases we just saw in the Talmud. The Talmud in both of these scenarios, in Bava Metzia and Sanhedrin, was talking about an individual who is at risk of dying and whether they can save themselves. Here, we're talking about doctors making an evaluation of whose life to prioritize, but they are not in need of treatment themselves. So it's a bit of a different situation. But I think we can see the ways that the Talmudic sources are still informing these rabbinic principles. And then finally, the final principle that both of our rabbis agree upon is that age should not be a relevant factor in determining priority or thinking about what they're calling sort of medical suitability, prognosis, or survival. So it's really about immediate survival, not sort of long-term life after the treatment. And they both say pretty explicitly, overall lifespan is in God's control. So even if we might think a 15-year-old is likely to have more life ahead of them than an 85-year-old, we actually can't know that. That can't factor into our decision. Providers should focus only on short-term recovery or survival. So if the 15-year-old is really, really ill, unlikely to recover, and the 85-year-old has a much better chance of recovery in the immediate term, the resource should be given to the 85-year-old, even if we think, well, they're probably only going to live, another 10 years. They still get priority because their immediate prognosis is better. And I just want to note that the first two principles here tend to be shared by most secular triage guidelines in secular hospitals. But there is debate over the last principle among secular doctors and medical ethicists. And we actually saw, specifically in COVID-19, different countries coming up with different guidelines about whether the patient's age should be a factor for whether they're prioritized for treatment or not. So just as some background. Okay, so now let's turn to our cases. So the first case we're going to think about comes from a case that was brought to Rav Moshe Feinstein, and it's recorded, his response is recorded in a collection of his writings known as the Igrot Moshe, which are a collection of his responsa, of his answers to halachic questions in a section called Care for the Critically Ill. So here's the case that was posed to him. Two patients are brought into the hospital, both in need of immediate emergency or critical care. One of them has a good possibility of being cured, but it is not absolutely certain that he needs intensive care, although this would be the preferred method of treatment. However, the second patient, for whom intensive care could only provide a postponement of death, cannot live at all without the attention of an ICU or intensive care unit. Which patient should be given the only bed available? And Rav Feinstein replies, I'm going to refer to these patients as patient A and patient B. So patient A is the one who has the better prognosis. Patient B is the one who treatment might postpone their death, but they're unlikely to recover. And he basically answers that if patient B, the more sick one, arrives first, and you give him the bed, you put him in the ICU, you hook him up to whatever he needs to be hooked up to, he's got all those resources, you cannot remove him once patient A arrives, even if patient A has a better chance of recovery. So once treatment has begun, and it is a life-saving type of treatment or a life-prolonging type of treatment, the person will die if you remove treatment. You cannot take that treatment away from you, away from this person. And he writes, and this is a direct quote from his response, the logic is obvious. The individual who can live only a short time is not obligated to forfeit his life for anyone else. Once he has taken possession of the hospital facility and his life depends upon continued treatment, even if his life be but of short duration, his claim takes precedence over all other claims. So that's if he's already hooked up to care. But Rav Feinstein argues, if patient A arrives second, so patient B is already there, the sicker patient's already there, but neither has begun treatment. That sicker patient hasn't already been given the bed, then the doctor can give the ICU bed to patient A, to the one who has a better chance of recovery. And he writes, again, this is the direct quote, the only time he, i.e. the sicker patient B, should be, the patient A, the one with the better chance of recovery, the only time he should not be given preference is when the critically ill patient who has no hope of cure has actually begun his treatment, has actually been already placed in the bed in the critical care unit. So up until the moment when treatment begins, we can prioritize based on medical suitability. But as soon as treatment has begun, you cannot remove the resource from that person, even if it doesn't seem to be saving them, even if you think it could save another life. And the logic there is you would be sort of actively involved in hastening their death or actively involved in killing them. So that's a sort of sense of active death that we saw in Sanhedrin of actively killing versus sort of taking a resource away from somebody. Now, Rav Feinstein passed away in 1986, so he never wrote anything directly addressing the current pandemic, but I think that many of the ideas we see here are, he was a giant in halachic thinking. He is one of the most important Orthodox thinkers of the 20th century, one of the most important Orthodox American rabbis. So his writings are really influential, and I think that many of the ideas we see him articulate here are surrounding similar kinds of questions that we see doctors facing during the pandemic, especially during surges when there are really a ton of patients who need care and there's definitely not enough medical supplies. And we saw that happening over and over again. We all saw those images of the hospitals and crowded ERs and crowded waiting rooms. And so this, I think, will help to frame Rav Asher Weiss, who is a rabbi in Israel, who is currently alive, so he's writing directly about the pandemic, how he responds to the second case. And this is specifically a question posed about a ventilator shortage and COVID-19. So the question is, if there's a limited supply of ventilators, and due to a pandemic surge or outbreak, the hospital anticipates receiving many patients who need ventilators very shortly. Can a doctor withhold a ventilator from a patient who does not have a high likelihood of recovery, even if no one else has yet arrived at the hospital? And also, can a physician disconnect the patient with no hope of survival from a ventilator to give it to a patient with a better prognosis? So here in his response, Rav Weiss agrees with Rav Feinstein on the case about taking the care away from a patient once it has begun. He writes, quote, once connected, one may not disconnect a patient from a ventilator regardless of their prognosis, even to save someone much more likely to survive. So both rabbis agree, once you start treatment, you cannot stop it. But now he takes an interesting take on this question of, what if we anticipate many more patients showing up, but there's nobody there yet, which is not an issue Rav Feinstein addressed. And he says, again, I quote from his writings, however, and I say this with tremendous fear and trepidation since we are dealing with life and death issues, if there truly becomes a ventilator shortage and patients are continuously arriving and requiring ventilation, then if a present patient has almost no chance of survival, it is my humble opinion that the medical team may withhold the ventilator from the present dying patient, the sick person in front of us, to save it for the patient with a much better prognosis who is certain to come soon. I think this is a really key moment in his thinking where he differentiates himself from several other halachic authorities. So he's basing himself here on a teaching of the Chazon Ish, who is also a very important Orthodox thinker, a Haredi thinker, about this idea of the dying patient in front of you, the Holei Bifneinu, and the patient who is quote unquote certain to come soon. So he's basically saying in the case of these surges, where we know that more patients are about to show up, then and only in those kinds of cases, we can withhold treatment from someone with a very poor prognosis. And I think the question at the heart of the dispute between these two rabbis has to do with whether or not the patient who's actually physically at the hospital has a right to receive care once he shows up. And if that right sort of only takes effect once he or she shows up. So of the patient with a poor prognosis, Rav Feinstein wrote, quote, once he has taken possession of the hospital facility and his life depends upon continued treatment, even if his life be of short duration, his claim takes precedence over all other claims. I see this as a contractual relationship with the hospital and the physicians. The care they provide was assigned to this terminally ill patient and no one can take it away from him. So in Rav Feinstein's mind, once the patient shows up at the hospital, he or she has a right to treatment. And you can only withhold that if there's somebody else right there standing in front of you who needs that treatment and who has a better prognosis. But Rav Weiss disagrees with that. He says in his response, quote, in my humble opinion, no such right exists. And he acknowledges that he's different from other halachic authorities on that. He may in fact even have Rav Feinstein in mind, but he says no such right exists. The patient did not buy the ventilator or acquire it in any other way. The only relevant discussion points here are the halachic considerations in medical triage. And he goes on to give this example that I found quite illuminating about why it could be acceptable to deny someone treatment in this kind of context, a treatment to someone who's physically present. He says, consider the following, and again, I'm quoting from his writings here. What would we do if a critically ill patient with almost no chance of survival arrived in the emergency room when there is one ventilator running, and the ambulance dispatcher informs the hospital that a young patient with an excellent chance of survival is en route and will need the ventilator? So they're going to show up for sure at the hospital in 10 minutes, let's say. In my opinion, we would reserve the ventilator for this patient. For Rav Weiss, the patient in the ambulance, it's as if he's already at the hospital and he can claim the right to the ventilator because he has a much better chance of recovery. And that is analogous in Rav Weiss's mind to, in the pandemic surge, that sense of certainty that another patient will show up very, very soon who will need the ventilator and who may have a better, or somebody will show up who will have a better prognosis, a better chance of recovery. Now, I think we should note that in the vast majority of cases, doctors cannot be certain that another patient will show up. So Rav Weiss's writing here really only applies to very extreme situations, like a pandemic surge, or again, like that example I gave at the beginning of the talk of an Army field hospital in the middle of a war where there's this patient streaming in all the time. In those cases, and only in those cases where the doctor can be certain somebody else is about to show up, Rav Weiss would say you can withhold the treatment. you can withhold the resource. If in sort of normal life, where we don't assume that patients are going to be streaming in, then I think Rav Weiss would agree with Rav Feinstein, you have to treat the patient who's actually there, whether or not they have a very good chance of recovery. If you have the resource that could prolong your life, you have to give it a try. Okay, so thus far, both of our sources from the Talmud and the contemporary cases we just talked about with the ICU bed or the ventilator, they've explored what I would call life and death scenarios, cases where whichever person does not receive the resource in question will die imminently. The stakes are both immediate and they're extremely high. And I think that considering these kinds of high stakes cases can be edifying because their intensity can help to clarify our ethical intuition. So as you were listening to the thinking of these two rabbis, my guess is that some of you found yourself agreeing with Rav Feinstein, some of you found yourself agreeing with Rav Weiss, and the extremity of the decision, the fact that somebody's going to die potentially based on this decision, can help our intuitions really come out very clearly for us. But I think that focusing too much on these extreme scenarios can also distract us from the kinds of ethical decisions that we actually confront in our everyday lives. These decisions, these everyday decisions, may feel lower stakes, but they are often just as nuanced and just as difficult to untangle. So now I want to draw on some of these same sources and ideas to think with you about a different type of ethical question that presented itself during the pandemic, and that is access to the COVID-19 vaccine or vaccines, right? We now have 3 that are under emergency use authorization in the United States, the Pfizer vaccine, the Moderna vaccine, and the Johnson & Johnson vaccine. And I think that the stakes around vaccines can also feel very high. After all, the vaccine prevents people from getting a potentially life-threatening disease. But the issues around access to the vaccine, who gets priority for the vaccine, I think are significantly different from the issues we saw with the ICU bed or the respirator, where those just 2 patients are present and we're deciding which one to give it to. First, other measures like social distancing and mask wearing have been proved to be effective to reduce people's risk of catching COVID. So unlike the case of the ICU bed or the ventilator, there are alternative measures that give people a good shot of staying healthy. And on the other hand, vaccines raise a host of ethical questions that the cases we just considered avoid. When the doctor is evaluating which patient gets the ICU bed, they are looking solely at that patient's medical prognosis. Who is most likely to recover and survive if given the treatment? And there's a certain sense of fairness to this approach. As there's a certain almost, nothing's ever fully objective, but it feels like a somewhat objective decision. This person has the better prognosis, this person gets the resource. Everyone is being evaluated at least according to the same medical criteria. But the case of vaccine access is very different. Not everyone has the same ability to socially distance. Certain people may not be able to work from home, or their jobs may require them to be physically close to other people, such as teachers, medical providers, nursing home staff. Others may live in small spaces that are occupied by many people. So if someone gets sick, it may be impossible for them to isolate. And each state has established different criteria about who to prioritize during the vaccine rollout, which means that someone with the same job and the same medical conditions in Texas might qualify for the vaccine, but someone with that job and medical condition in Massachusetts might not qualify for the vaccine. So people with identical scenarios in different places may have different access to the vaccine or vaccines. And finally, people also have different degrees of technological literacy and access. So if you need to sign up on an online registry or check a pharmacy's website repeatedly to look for an appointment, some people are going to be much more able to do that than others. And I will say this is not sort of theoretical. This was a major issue. I live in Washington, D.C. There was a major issue here with people from different districts just being better at finding appointments, different wards in the city, and going across the city to get vaccines, and people in those wards not having access. So they actually changed the vaccine rollout here to give priority to the underserved wards. But this is even something like technological literacy that might seem minor can actually really affect who got the vaccine first. So as a result of all of these different factors, concerns about equity and fair treatment have come into play around the vaccine rollout in a different way than in the cases we talked about with the ICU bed or ventilator. And to make this more concrete, I want to present to you a case that was published in the ethicist column in the New York Times Magazine. So I don't know if you're familiar with this column, but it's quite interesting because in some ways it's actually very similar in structure to halakhic tradition, where someone writes into a rabbi what's known as a shaila, a question, and then the rabbi gives their responsa, their halakhic answer. Here, people write into the ethicist. In this case, it's a secular ethicist, Kwame Anthony Appiah, and he gives them the ethical answer, right? Or his ethical answer. But the structure is actually quite similar. And so let's look at this question that was posed about the vaccine. So someone wrote in, I don't know who this person is. I'm just going to refer to this person as a woman just to make it easy for pronouns. So I work for a hospital, but in an administrative job. I do not interact with patients. I've worked from home since March. I am not at high risk for contracting COVID-19 based on my age, occupation, and lack of health issues. I practice social distancing. I wear my mask in the limited situations in which I go out to the grocery store, to the post office to get takeout. I live alone and mostly keep to myself and stay home. Because I work for a hospital, I'm eligible to receive the vaccine as part of the second group in my state after first responders, hospital personnel who interact with patients, and people living or working in nursing homes, along with people who are 65 and older, medically vulnerable people, and corrections officers. This means I would be vaccinated in the next week or two. If I worked for any other employer, for example, I used to work at a bank, I wouldn't be eligible to receive the vaccine until the second to last or last group of the population, probably not for several months. Is it ethical for me to get the vaccine now? So that's the question this person posed. And it was really struck me because I recently had a conversation, a similar conversation with a friend who has a qualifying medical condition, so became eligible to get the vaccine here in DC. But he felt that his illness was mild compared to many of the other people who qualified in the same tier or phase of the rollout. So again, this is different in different places, but DC made the vaccine available, although there's not enough appointments yet for everyone who wants them, but they made the vaccine available to people with a host of different medical conditions. And this is a wide range of issues, some of which seem to potentially be more severe in terms of their health consequences than others, at least in the mind of this friend. So even though he technically qualified, he wondered if it was right for him to get the vaccine now and potentially take it away from someone who needed it more. So how should we think about these kinds of questions? And what guidance, if any, does Jewish tradition provide? And in some ways, this is where I'm going to try to bring this full circle a little bit. I actually think this question is related to our discussion of Lifnei Mishurat Hadin in my last talk, this what I called sort of contextual decision making, which that phrase literally translated to acting within the line of the law. Not only is it perfectly legal for the person who wrote into the New York Times and for my friend with a qualifying condition to get the vaccine, since they've both met the criteria for eligibility, but this is in fact what we would expect them to do. Like many rules, the guidelines establish a narrative script. We expect people who want the vaccine to register for an appointment as soon as they're able to do so. So they're not required to register for the vaccine, but the fact that they're eligible creates our expectation that they will do so if they want to get a vaccine at all. Now, of course, they don't have to. No one is legally required to get the vaccine now, since it only has an emergency use authorization. And it's worth noting that at a future point, if it becomes fully authorized by the FDA, legally certain employers or schools could require people to be vaccinated to work at those institutions or attend those institutions, but that's not the case right now. No one is legally required to get it. And also, nothing bars the woman in this case study or my friend from getting the vaccine at a later date when it becomes available to the general population. So nothing makes them have to do it now, even if they want to get the vaccine. And in this sense, they face scenarios very like the ones the rabbis in the Talmud faced when they opted to act for Lifnei Mishurat Hadin, but with one important caveat. They do not know who their actions will impact. So in all the case studies we saw of rabbis acting Lifnei Mishurat Hadin in the previous talk, they knew who their actions were going to affect, right? Rabbi Chia, who was the banker, right, knew that if he repaid his client, she would get the money. Rabbi Ishmael, who met the man carrying sticks on the road, knew that if he did certain things, he'd be helping that individual man. But in this case, if the person in this case study or my friend forgo their vaccine access, at least for now, they don't know who they're going to help. Maybe if my friend chooses not to get the vaccine now, it will go to someone with a more serious medical condition, but maybe it'll go to someone like the person who wrote into the New York Times who actually has less of a pressing need medically to get the vaccine than he does. So in his response to this question, the ethicist columnist Kwame Anthony Appiah argued that the person should go ahead and get the vaccine without any qualms. And this is part of what he wrote. He says, whatever rules we make for vaccination priority, there will be trade-offs. We want to minimize the total number of people who become severely or even fatally ill from the disease. We want to protect those whose necessary work puts them at risk of their exposure to the virus. And we want to be fair, treating similarly situated people alike. These desiderata don't all pull in the same direction. Healthcare workers who are in their 20s and don't have certain medical conditions aren't at high risk if they contract COVID-19. Perhaps we could save more lives if we left them until later. But there's another overall desideratum. The system has to be straightforward enough to be managed easily, to get large numbers of people vaccinated as swiftly as possible. We don't want to have to determine that people meet a dozen conditions before putting the vaccine into their arms. Doing so could slow down the rate of vaccination. Any system that makes a reasonable attempt to be efficient and equitable in achieving the goal of reducing the harm done by the pandemic is acceptable, despite the questionable outcomes produced in particular cases. And here I think Appiah actually makes an argument that is similar to the one we saw Rav Nachman make in the lost property case we talked about during our first meeting. So if you weren't here, the discussion was about a lost purse that was found in a marketplace. And for various reasons, this was determined to be a finder's keeper situation in rabbinic law. So the person who found the purse could keep it. But then the original owner unexpectedly showed up and asked for their purse back. And Rav Nachman argued that despite this, the finder does not need to give the purse back. Yes, the rule that the finder was allowed to keep the purse didn't really have the situation in mind, since the rabbis assumed the purse's owner would have given up his claim to it. But for Rav Nachman, that didn't change anything. There will always be rules that won't apply perfectly, and this is one of them. It's still a good rule. Similarly, Appiah argues that at a system design level, the perfect could be the enemy of the good. In order to get the vaccine quickly distributed to a large number of people, we have to treat certain groups as if they are homogenous. Certainly, the administrative assistant can keep her distance from patients who might have COVID-19 much more easily than the ER doctor. And in an ideal world, we'd give the shot to all of the ER doctors first. But in order to make it feasible to distribute the shots quickly, the system treats everyone who works at the hospital in the same way. And I think it's worth noting that Appiah actually has a good point here that's been borne out by the evidence. There's evidence showing that states like West Virginia, who did not worry too much about making sure people met certain qualifications before vaccinating them, were able to vaccinate a much larger percentage of their population much more quickly than states like New York, who refused to give the vaccine to people who did not qualify for it, according to their different phases or tiered systems. And those states like New York even allowed the doses to expire rather than giving them to people who were not yet eligible. So it's not just sort of a theoretical argument. In practice, making there be too many barriers, making sure people meet too many qualifications in the goal of being equitable can actually really backfire and stop us from vaccinating as many people. But I also think that we could argue that Appiah is answering a different question than the one he was asked. We can understand why it was necessary to design the system this way, and everyone agrees that the individuals in this scenario are not transgressing in any way if they make an appointment and get their shot. So the woman who wrote in she is perfectly within her rights to get her shot now that she qualifies. But what is morally acceptable and what is morally best are not the same question. The person who wrote in to Appiah clearly thinks that the best outcome may be to wait and get the vaccine later, since she works from home and has very limited social interactions. Someone else in the same tier or phase may actually be at greater risk to contract COVID-19 and therefore would benefit more from getting the vaccine quickly. And in such cases, I think we might draw on rabbinic sources about lifesaving hadin to argue that she is not required to forego the opportunity to get the vaccine now. It is fully within her rights to get it. We cannot expect or ask her to delay, but we might also draw on those sources to note that we have models from rabbinic tradition that would support the idea of her waiting and even suggest that it is praiseworthy to do so. So in closing our study of these cases, I just want to note something structural about the argument I've just made. The sources about acting lifesaving hadin in the Talmud do not address medical questions or life and death issues. And as a result, they're probably not the first place most of us would look when we think about questions of bioethics or medical decisions in light of COVID-19. And they would not be the right place to look in the discussion of the cases of medical triage that we started off within the lecture, a question about the ICU bed or access to the ventilator. Those cases and the questions that they raise are just too different from the sources on Leafy Mishra-Hadin. But the question at the heart of the vaccine case that we're considering is not really about triage. It's not really about a medical evaluation or about some of the same issues that come up in those first cases. It is about personal responsibility and about the degree to which it is right to prioritize our own interests at the potential expense of those who are more vulnerable than us. Those are questions that are also activated by the sources about Leafy Mishra-Hadin, and therefore I think they are reasonable sources to turn towards. So I hope that in thinking through these different cases with you, I've been able to show how some of the ideas that I introduced last weekend about engaging the Talmud as a conversation partner and about Leafy Mishra-Hadin as an alternative model of decision-making can actually help to guide our thinking and practice and reach some very concrete decisions in the kinds of cases people are thinking about today in the pandemic. I also hope that in thinking through these cases, we've been able to explore some of the ways that the ancient wisdom of rabbinic tradition might be able to provide guidance during these times, even though many aspects of the pandemic are unprecedented. So now I know I introduced a lot of different cases here. Each of these cases, I think, poses a lot of different issues and questions. So I love to turn it to discussion. I'm gonna stop my share of the screen so that I can see you all. I'd love to hear what kinds of questions these sources raised for you, which responses you thought made the most sense. So.
Thank you so much, Dr. Bear. So there's a couple questions already in the chat, but if there are other folks who are around who are like me, you might need a second to process. And Debbie has her hand up. And oh, there's a couple other human hands up, not just digital hands up. Great. I saw, sorry, you waved your hands once and then I didn't catch who you were. Okay, Basil and the Salzburgs. Great. And I guess, Suzanne, you put some questions in the chat, but I don't know if you would rather just have a chance to share them aloud and kind of get in the stack that way. Would that work for you?
Leave me alone. She didn't talk to me. Oh, sorry. Did you say that I could speak or not?
Yes, I'm still establishing a stack and seeing who exactly is in it. So just 1 second.
Sure. Do you want me to start off then, or?
No, I want to know if you want to get in the order of folks
Sure,
to speak,
sure.
so you can verbalize your own questions
Okay.
rather than me reading them. Okay, so we'll go Debbie, Basil, Elise, and then Suzanne.
The case about holding a ventilator for somebody who's not there yet reminded me of a news item that I recently heard. Apparently, the US is sitting on a stockpile of AstraZeneca, even though we haven't approved it yet, in anticipation that we might approve it. And some other countries that have approved it are begging us to hand over those doses to them for immediate use. So there's kind of two questions wrapped up in there. One is again, this issue of, can you hold on to a resource for yourself or for someone for later, even if somebody else needs it now? And then there's also the sort of national level of the question of how much can you prioritize yourself over somebody else. My kids, who are teenagers and very idealistic, are kind of up in arms about the idea that there are these national borders and that, that why would we prioritize American lives over some other countries' lives? And I say, well, just because we're us and we're taking care of our own first. So I'm curious how you think some of these contemporary rabbis or some of these traditional rabbinic sources might respond to that.
Yeah, thank you for that question. It's a great parallel and a really provocative parallel of sort of shepherding resources that we know as soon as assuming that the AstraZeneca is approved, we know that there are people who would want to have it immediately. But we also, that process could take a long time, and there are people who need it right now. So I think that's a very interesting structural parallel to the example of the ventilator. And so I can't speak for the rabbis that I'm not Rav Feinstein or Rav Weiss. I can't say what they would say, but my sense of reading Rav Weiss's response to this issue is that it's really about immediate certain need. So in his mind, in the case of a pandemic surge, even if you didn't get the call from the ambulance driver that says, I'm coming in with a guy who's going to need the ventilator but has an excellent prognosis, it's as if the doctor has that call, because we can be so certain that multiple people are going to flood through the door in the next hour or 2 hours who need it, not a month from now or two. I mean, the FDA's emergency use authorization process is not a super quick one, although it is moving very quickly compared to normal times. But still, it's not like tomorrow those would be released or approved. So my guess would be that on his logic, that's not a immediate enough certainty of use, or that at least his response would allow for us to argue that we're talking about both immediate and certain need rather than certain need but down the line. I think, though, that looking at rabbinic sources, and I think I mentioned this in a previous talk, but rabbinic sources, especially when they talk about pikuach nefesh and the need to save a life and how you can do almost anything to save a life, sometimes only extend that to the saving of Jewish lives. They don't actually always extend that to the saving of all lives. And we may, as readers, approve of that or disapprove of that. We may find that morally problematic. But there are certainly in the sources an idea of an in-group whose well-being you can prioritize over the out-group that we might see as an analogy to the kinds of national borders you're talking about. So we might see resources or ideas in the classical sources that would support the idea of reserving resources for the nation, in this case, the nation of the United States, not the nation of Israel, but a similar kind of idea of the in-group over those who are not in the group. I will say personally, I do not agree with that line of thinking in rabbinic sources. I find it troublesome when it comes to life-saving. I don't think it's always bad to prioritize the in-group over others, but when it comes to sort of this kind of extreme, people will die, I find it very hard to, for me personally, to justify that. So going back to my first talk, there are times when we read rabbinic sources where your moral or ethical intuitions or commitments are not going to be the same as those of the rabbis. And we as readers have to contend and figure out what to do with that. So I would be disingenuous if I didn't say this is a case where my personal, if I were writing ethical guidance, would probably look different. But there are those sources that might be useful, I think, still to think with and think around to help clarify, even if you wanted to read them, to clarify why you think actually it's not okay to save the resource for the nation. Or maybe you want to use those sources to say you think it is okay to save those resources for some in-groups, but not other in-groups. Maybe we're okay drawing boundaries based on nation, but not based on religion. We might all as readers come to different conclusions. But I think they would be fruitful sources to think with around that question.
Thank you so much.
Yeah, thank you. It's a great question.
So next is Basil.
Can you hear me?
Mm-hmm.
So what I'm struggling with when I listen to your examples is you frame it as ethical questions, but I'm thinking that a lot of it has to do with practical decisions and logic and medical knowledge of a particular situation. So for example, if you have two patients coming into the hospital that need ventilators simultaneously, and one is older and one is younger, but the older one has a better short-term prognosis, the argument was you should favor the older one.
Correct.
So I could argue that that is based to a large extent on practical matters and is based on medical science to judge which person has a better short-term prognosis. and doesn't have so much to do with ethics. So in many examples, I think I could make that argument. Sometimes there's both an ethical and a practical. So how do you deal with that?
Yeah, excellent. It's a
Okay,
great
that's-
question. And I think a large part of these questions do actually are actually based on medical expertise and medical knowledge. But to go with the example that you gave, the older person has the better prognosis for treatment, the younger person has a poorer prognosis for treatment. It is notable that several different countries came out with guidelines about assessing priority of treatment during the pandemic for access to things like ventilators precisely. And some of them said the age of the patient should be a partially determining factor or taken into consideration, and some of them said it should not. And that, I think, was an ethical decision about how much do we prioritize potential life and potential lifespan, how much do we prioritize different sectors of our society. There's lots of different questions, I think ethical questions that come into do with once you've made the medical determination, how then to allocate the resource. And actually, the issue of age, this is a case where our halachic thinkers all agree it should not be relevant. But in making that statement, they're articulating what I would say is a moral principle. Or you could understand it as a religious principle that God is in control of a person's lifespan, and we have no right to base our decisions based on that. That's in God's hands. What we have the right to do in our role as doctors or humans is to determine who has best sort of immediate treatment. And I will say that often these questions are presented in responsa or in these kinds of ethical forums as these sort of clear-cut cases, right? In that case, older patient definitely has a better prognosis, younger patient definitely has a worse prognosis. But often part of the challenge is they have different potential complications, and different doctors will make different assessments about which one has the better prognosis. And you can have a team of doctors disagreeing about which one should get the treatment. So I had the opportunity to sit in at what's known as an ethics consult service at a hospital for several months. And what that service does is basically help the doctors who are in moral distress over making these kinds of decisions, because they feel like the medical determination is not fully clear, and that can lead to a lot of ethical distress. And often the role of the consult service is helping to separate out for the doctor, what is the medical question? What are you medically unclear about versus what is the ethical question that you're wondering about? And sometimes they're directly tied together. They feel like they're not clear on the medical issues, and therefore they can't make a good ethical determination. But sometimes in conversation, they get more differentiated from each other. So I saw cases of, how much can we override? One person in the family really wants to pursue treatment, and one person in the family really doesn't. And what is our role in guiding that decision, which is not necessarily about medical prognosis, but is still often an ethical question that doctors are brought into. So I think it's a great question. And I think sometimes actually just separating those things out can give people a degree of confidence in their decisions. They actually, I do have medical expertise. I really do think this patient has the best prognosis. And so I can be confident in my decision to treat them, because doctors experience a lot of distress about not treating people who need treatment. I mean, it's just their goal in life is to save people's lives. And it's extremely upsetting to not be able to treat everybody who needs treatment. So I think that getting clear on those issues can also be sort of helpful to address that kind of moral distress.
Thank
I don't
you.
know if that answers your question satisfactorily, but.
No, thank you. Very helpful. Thank you.
Next is Elise.
Hi.
Hi.
I wanted to talk about the patients who are coming to the hospital. I was in Florida at the time of the Parkland high school shootings, and North Broward Hospital, which is the closest hospital, I was actually at the rehab center right across the street from that hospital, and
Oh, wow.
I was visiting. My father was in the rehab, and his girlfriend was in the hospital with pneumonia. The hospital knew, of course, the shootings, and they cordoned everything off immediately. And they didn't know whether they were going to have 10 people rushing to the hospital or 100 people or a 500. So basically what they did was they kicked out everybody who was in the hospital. If you were breathing on, if you were on a ventilator, they weren't going to kick you off. But
Right. But if you could survive independently.
if you could breathe on your own and you could sort of half make your way out to the parking lot on your own with a wheelchair or whatever, they discharged you from the hospital, including some people who were very, very sick. And who really, so they were making a choice of prioritizing the incoming potential patients, as it was not a certainty that they were going to need all these different beds, but they were prioritizing these the victims of the shooting over people who were already hooked up to the resources. So that's
very
the opposite of what the rabbis would say, that if the person who's already in the hospital, they get precedence over the newcomer. They did the opposite.
That's very interesting. But I think that there's, I mean, one of the key things that you said there that I think is very relevant is that they disconnected people from resources if they were able to survive without them. And so I think that's really key to the writings of the rabbis that we saw, is that we're talking really about, right, they didn't disconnect people who couldn't breathe on their own from life support. And that those are the kinds of scenarios that are in mind in these cases, are this patient will not continue to survive, will not continue to be alive without being attached to this resource. And then I think you have a really interesting question, and sort of has to do specifically with how they dealt with it, which I don't know the particulars of that particular situation, but of, you know, how do you reconnect people to resources? How do you filter through everybody who is now in the parking lot, who may have greater or less severity of disease based on, or of wounds, of other kinds of things, right, based on what resources are now available. But I also think one of the things that's interesting about that case is that these senses of disaster, right, of tragedy, often galvanize people in a different way and say, okay, you know, we need to focus all of our attentions on this. And it's actually interesting. There are probably many lives that have been lost during the current pandemic because people didn't want to go to the hospital because they were afraid of contracting COVID at the ER, and then they had heart attacks in their home or something like that and did not survive. But also people who have serious illnesses who are going to participate in clinical trials that were canceled, as all of those resources, all of those researchers redirected their attention to the pandemic. So there are lots of sort of unseen casualties of paying all of your attention to one thing. And I think it's a very human response to sort of focus on emergency. And it's also in many ways an admirable response. The way so many doctors pivoted to the problem of the pandemic got us to a vaccine much more quickly than any other time in history, right? It's actually incredibly impressive. But there are a lot of people who are sort of like those people in the parking lot in relation to the Parkland victims, who have real medical needs that are not necessarily getting the medical care that they would normally get because of the situation. So it can get very messy. It's not always patient A and patient B, one resource we pick who gets the ventilator. It's often this person, they're not dying immediately, maybe we can put them off a little bit longer, but then if you put them off, maybe their situation changes, now they're no longer able to, that treatment will no longer help them. So it gets very, very complicated. Yeah, and it's a great example of how that can happen. Thank you.
So next in the stack is Suzanne. Yeah, I can add other folks. Hannah, do you want me to add you to the queue? Okay.
Yes, David wants to be added.
Oh, great, David.
Hi, thank you so much. Your talks really give us a lot to think about. I think, I know I tend to put a lot of stream of consciousness just in the chat and so on. I'm interested in your or everybody's take on, I reference this as utilitarianism and that's one moral way to do moral decision making, as I understand it. And there are other ways, other things Kant says and other folks about absolute moral reckoning. So we can call that pragmatism or utilitarianism. I think it's very attractive to Americans. The best good for, the most number of people. It's kind of like a calculus. As an engineer, we, think in terms of algorithms. And I just want to point out and again, get your take on this question of age was really fascinating to me. And we even heard people in America say the quiet part out loud of you're 80, you're whatever. That's fine. That's it. And again, that's great fodder for science fiction. All kinds of science fiction of, limited resources. You're 30 years old. That's it. You've reproduced, and you get people like Peter Singer. I don't. And so his thinking then extends to say, is the life of a person with disabilities actually inherently greater than the life of an endangered chimpanzee, and so how do you do that calculus? So I just found that point very interesting. I don't know if you have additional comments on it, and the rabbinic answer to it, which is that we don't have the time horizon, to use the computer science with it. We don't know what the future is going to be. Now, you both could only have that bottle of water in the desert, but who knows what could happen? Anything can happen. Maybe you both can survive. So you shouldn't maybe put your timeline out too far. And I'm wondering if that is, if I'm taking away the right conclusion.
Yeah, I think it's great that you brought in those moral theories. And I think that I understand the rabbis we saw, Rav Feinstein and Rav Weiss, as engaging with some degree with utilitarian or consequentialist thinking, this sort of maximize life. And I think they're inspired by Jewish principles there about the sanctity of life, the importance of saving life. But I think it's definitely a modified utilitarianism, because not only that age is irrelevant, but a sort of extreme utilitarian would definitely say the person who's on the ventilator or in the ICU bed who is not recovering, take them off it and give it to the next person, right? Time limit expired, this person's got a better chance. If your goal is really like a calculus equation, A plus B equals most life possible, you're going to take resources away from people who are not improving with their use. And I have never seen a halachic writer who found that acceptable. That's one of the few points that, I'm sure they're out there, but it's one of the few points that I've seen remarkable consistency among rabbinic thinkers on medical issues. This idea of you can't kill, they see that functionally as killing somebody, and that you cannot do that. I see lots of rabbinic thinkers who say it's okay not to put them on it in the first place. Postpone putting them on it if you want to. Even if there's nobody else there who needs the resource, you can decide just not to pursue that kind of treatment. That there you see a much wider range of thought among different people, when it seems like the chance of it actually helping is very low. When we're talking about what doctors would say is not the standard of care, but sort of extraordinary measures. But I'm sure it's out there, but there's actually a really surprising consistency among the sources I've read that say you can't do that. And I think that's placing limits on that kind of utilitarian focus. And so maybe the term I used about pragmatism is a helpful one here. of saying we want to make practical decisions that are going to yield sort of, we're thinking about outcome, right? It's consequentialist in that way. We're thinking about outcome. We're thinking about trying to maximize life. We're guided by these principles, but we're not pursuing that. We're doing that in a bounded way. We have other things that influence our thinking about what a good outcome is, not simply sort of quantity of life. And I think those are really important checks. And often, I also think that that's not actually unusual. So if you study moral theory, and Peter Singer's a great example of someone who's really on an extreme end of a certain trend of thought, but lots of people are consequentialist or in they're thinking about outcomes in their orientation, but also have certain kinds of absolute moral principles that they're unwilling to violate. That's sort of more what we might say kind of in a Kantian framework, or so it's rare, I think, to actually find a thinker who's all in one camp and is not influenced by other factors as well. That's a great question.
Thank
I
you.
put myself in the stack.
Yeah, great.
The question that was on my mind, I've been not for any personal reasons, but studying about what are the situations in which you might kill a murderer. And so I wonder, and specifically looking at the Rambam's stuff, and been thinking about the choices that he makes, or that he understands the sources as making around the kind of, when do you cede that kind of responsibility onto an individual or not? And so I guess that's the question I'm left with thinking about with regards to the case of the vaccine. And what do you think of the having that kind of, when I forgot what the ethicist's name is, but when he's responding to her, how much is he responding to her individually versus how much is he writing publicly and knowing that he's going to be influencing the system by the answer he gives, right? Because that has a different thing. And what's the incentive? How might we think about whether we want people thinking as individuals about this, or we don't want people thinking about individuals thinking about this.
I think
individuals.
I think that's a great point that you raised, and he's definitely writing it. I mean, he's writing in the New York Times Magazine. He is very self-consciously writing in a public forum. And I think in some ways that's part of why his answer is addressed to everyone reading the column. It's not just addressed to that individual. And he's arguing about systematic design and issues of public health. So, I mean, ultimately his argument has to do with, we just need to get as many people vaccinated as we can, because that's how we reach herd immunity, if we ever reach herd immunity. And if we worry, it's laudable that you're worrying about these things, but if we worry too much about whether it's okay for us to get the vaccine when our eligibility comes up, then we could sort of slow down the whole system and actually end up, that could have more harmful effects, right? You're thinking about it as I, as an individual, might be taking this vaccine from this other person, but he's thinking about it as, let's just get all these people who, for whatever reason, can't get the vaccine because we just don't have enough of it. They're going to be protected by you getting vaccinated and by everybody who has the opportunity to get vaccinated getting vaccinated, because that's the whole concept of herd immunity, right? The more people who are vaccinated or have immunity to an illness, the harder it is to catch it. So I think you're right. The sort of public nature of his response definitely impacts what he decides to prioritize. And I also think that that you make a really important point, that on the one hand, we might say, based on the sources that I was pointing to, maybe it is morally laudable to say, I'll wait until I know that someone's going to scoop up my appointment slot if I don't take it. And I'll wait until I'm going to get vaccinated, but I'll wait until the general population so that somebody who I think is more vulnerable than me can have this opportunity now. And we might also say that person should instead think, hey, I'm doing my part for the greater good. I'm going to get vaccinated because I think everybody should get vaccinated. And this is when my opportunity came. And so I'm doing it. And that is actually the morally laudable, that sort of collective mindset of, we all should do this when our time comes, and this is my time, so I'm doing it. I think could also be seen as a not just an acceptable approach, but you could argue that that is actually, you're setting a good example kind of approach for other people to say, because part of this conversation that I didn't talk about, but there's a huge amount still of vaccine hesitancy, right? There's a huge number of people who, I think the numbers I've seen most recently are around 20% of people who don't want to get the vaccine, even when it becomes available to them. So you could argue that if you think it's important for everybody to get vaccinated, I don't know if I don't know how much you all are on social media and Facebook and things like that, but I feel like my feed of social media, which I don't think is unique, is just like vaccine selfies all the time. People saying I got vaccinated. I saw like Barack Obama and Michelle Obama taking vaccine selfies. I follow them on social media. And that's a public way of saying you should, it's not just saying, yay, look at me, I got vaccinated, and to all of you who didn't get it. That's not what's going on at all. They're saying you should do this when the time comes. This is a public good that we're contributing to. And that's an important side of, I think, his argument and of what you're saying, Rabbi Katz. So just thank you, being conscientious of time. We've got 3 questions on Stack. Anybody else have? Yeah, right. Including yours, Hannah. Is there anybody else? All right, so we'll close after that. So somebody wrote in and asked if you could say a word about the Chazon Ish. Yes, the Chazon Ish, really important thinker in what's now often referred to as the Haredi community. Sort of, if you've ever heard of the Das Torah movement, the idea that all guidelines for life come from the Torah. He's a really important thinker within that framework. So he is what we might think of as very traditional or on the right of some kinds of spectrums, extremely, extremely authoritative to many thinkers. Really fascinating, really highly learned individual. And I think that's part of why Rav Weiss, who's also would be classified as Haredi, if that's a classification that means something to you in Israel, sort of ultra-Orthodox is the word we often use here. I think that's part of why Rav Weiss cites him, because he is widely, widely respected as a halachic thinker. And I think that on some degree, Rav Weiss probably feels that what he's saying is potentially controversial. He knows he's going in a somewhat different direction than some other rabbis have, than figures like Rav Feinstein might go. Who's also extremely well-known and well-respected. And he's saying, look, this is a very typical move in halakhic thought. This isn't my innovation. I am applying the thought of an authority that we all respect in doing this. And so that's part of why he's citing the Chazon Ish in particular, because he's such a canonical, for lack of a better word, thinker in that community. Does that help situate a little bit? I'm not an expert in the Chazon Ish, but he's a really interesting figure. I think that was great. All right, then we have Hannah and then David.
So I actually, like some other people, I wanted to share a real situation, and that's related to what happened during the advisory committee for the FDA. They had to decide on the emergency use authorization of these vaccines that most of us have been lucky to receive. So as you know, most clinical trials, in order to lead to approval, has to be what's called randomized blind trials. And the integrity of the trials is very, very important if you ask any statistician. And it has to, actually it requires participants to sign a consent form that they're willing, that they know that they can either get the vaccine or not, or a placebo, and they may have to be on the trial for at least a year or even more before they even know what did they get. And normally it's eventually lead to licensure, and after that there is a recommendation by the CDC and everybody get it. But EUA are very different because it really happened relatively early during the trials. It's called interim analysis. It was based on certain number of cases that then the committee, unblinded committee, looked to see how many cases were in the vaccine versus the placebo arm. And during this discussion, the big decision. There were at least several ethicists that participated. If we now have a vaccine that is starting to be distributed under EUA, what are we going to do with the placebo group? Should we automatically, ethically, have to give it to them? Should we only give it to people that will be sort of allowed already in the highest tier? And under which condition? And is it ethically okay actually not to give it to them in order to maintain the integrity of the study, so we can really know whether this vaccine works, not only for just 2 months, but 6 months post-vaccination, etc. So I can tell you what was decided, but I would like to hear from you. What do you think the rabbis will come here?
Oh, that's a great question. It's such a tough ethical question, because on the one, and I think, I don't know what the rabbis would say, but I think the questions that come to mind for me, or I mean, you really articulated this so well, but it's the question of how much, it connects to the question we saw Rav Weiss addressing, because it has to do with how much do you prioritize sort of immediate need versus anticipated future potential need. So the longer the study runs in its randomized blind format, the more information we have about the efficacy of the vaccines long term, about how they work, about how effective they are, and if they're effective against different strains and all of these different things. And that information is potentially helpful not only for treating COVID, but also for future pandemics where new viruses come up, where we need to draw on the existing medical research to try to come up with new vaccines. So it's not isolated from, you know, potential new emergency cases. But on the other hand, there is this, I think, a real argument to be said that these people volunteered, you know, for science, and they should not be punished as a result to not be getting access to the vaccine. You could say they knew what they were getting into, they agreed to X period of time. And I think I think, you know, sort of going back to what I think it was Basil said about there's the medical, for me, I would want to know a lot of the medical, I'm not a medical expert, so I'd want to know a lot of the medical opinions about what do you gain from that data, understand better what its potential uses are if you keep it blinded. I know actually, so they're starting trials in pregnant women, and I know that part of the condition of that trial is that they will unblind once the infant is born, and they will give the woman in the trial the vaccine if she receives the placebo. And I think that is an interesting way of trying to deal with it, right? Is that going in, people know that they're signing up for this sort of shorter term thing. But I mean, again, I'm not a medical researcher, so maybe that doesn't give us, it gives us information for the full term of the pregnancy, and you can track the infant after pregnancy, which is often what people are concerned about, right? Do these vaccines have an impact on infants during gestation? But maybe you'd get more information if you waited longer through, you know, nursing and all of these things. So all that to say, I don't have a good answer about what the rabbis would say. But the thing that I find helpful about reading rabbinic sources for me is a training in a pattern of thinking about what kinds of questions that I should ask. So those are some of the questions that come to mind for me that I would imagine, because the rabbis we've seen writing about triage ethics are focused on, to some degree, maximizing lives, but in sort of the immediate or short term, but also have a sort of long-term view about what's in human control, what's not in human control. That I think those are the kinds of questions they would maybe want to ask, but I don't know how they would answer them, which I'm sure is unsatisfying. But it's an excellent. Those are such thorny moral questions, and they're precisely the kinds of questions that people have to answer. You can't just sit on them and say, I don't know, it's too hard, I don't want to answer it. Somebody's got to decide those things, because people want the vaccines. And it's actually interesting, I will say, there was a column in The Ethicist where somebody wrote in saying that they had participated in a trial. They were one of these people. And they were relatively sure that they'd gotten the placebo because they then seemed to have contracted COVID. So, and now they want to know, people who've gotten COVID can still get a vaccine. They want to know, can they sort of like unblind themselves functionally and get the vaccine? Is that moral to do when they agreed to a contract that said that they would, follow the study and whatever? And Appia sort of wrote on the argument that you shouldn't participate in the trial if you're not willing to abide by the terms, as sympathetic as he was to their concern. So it's not a rabbinic view, but you can see people kind of falling on both sides.
Not easy question.
No.
So our last question goes to David.
Hi, I'm a practicing physician and I'm on the ethics committee at our hospital.
Oh, great.
We were helped out because there is a document that was prepared by the state of Maryland several years ago about how to allocate resources during a pandemic. And so that's
wonderful.
That really has been of great help. When we have sick patients, it often is a practical issue of trying to take care of patients. You don't have time for ethical considerations. Literally, you have a couple of minutes to make decisions. So we those need a lot of continuing help and input about end of life decisions, or once these people are initially stabilized, to try to make those decisions. We still do a poor job in that. And finally, I want to comment the issue of vaccinating nursing home patients first. That created a lot of angst among practicing physicians. There was hardly any agreement among people about whether we should do that. And there still is concerns about doing that. So the practical and the theoretical often butt heads in the practice of medicine. So.
Yeah, absolutely. Thank you for providing that perspective from the medical perspective.
Sure.
And I think I will say, and I don't know if this corresponds to your experience on the ethics committee, but often I remember sitting on a case that actually the person came to the ethics consult service after the patient in question had already passed away. So they were no longer in the process of making a decision about how to treat this patient. This patient was no longer alive and could no longer be treated. But they still wanted to think through what they should have done, because these cases keep coming, similar cases keep coming up, and they wanted to be more confident in their assessment next time around, even if you're never going to get exactly the same case. And I think that is a lot of the role of this kind of conversation and this kind of reflection. And it's wonderful that the state of Maryland had the foresight to give a guidance document for a pandemic, even if, I don't know what the document looks like, even if parts of it didn't apply perfectly or seen as problematic, you had something to start with. But a lot of what people are doing now is in the moment trying to reverse engineer one of those documents. And as much as I hope we will never be faced with another pandemic like this, we have a lot of knowledge, but also a lot of sort of insight into what kinds of questions might come up should we face a future scenario that's analogous in some kind of way. And hopefully that can help people make, even while the medical knowledge may be very different or the medical issues may be very different, help people make decisions confidently.
Please get it.
Next time around. So yeah, thank you for sharing that.
Sure.
Dr. Bear, I just want to say in conclusion, I really appreciate the way you brought for us today a very high level question that many of us are not responsible for making these decisions of what happens at the hospital. Some of us do, but most of us don't, but are very much on our minds, and also a decision that all of us have to make about, are we going to get vaccinated when we are able to? And the way that you showed us how rabbinic sources help us break apart the different kinds of questions and the different ways that we might kind of continue working on ourselves and making better decisions for ourselves, as well as the knowledge that comes through living through a particular time and the questions that it raises. So thank you for enhancing all of our learning this year.
Thank you for having me. It's been such a pleasure learning with all of you these past couple of weeks. So I've really enjoyed our conversations, and I hope we have a chance to learn together again at some point.
And I thank you, and I thank everybody for attending. Thank you very much, Professor Bear.
All right.
Have a good evening.
Okay, good evening.
Night.
Good night.
Good evening.